أهلا بيكم. In this lecture, we'll continue our talk uh, about the thoracic wall. We studied the bony framework, and today we're going to study the muscles and the blood and nerve supply. So let's go. The muscles of the thoracic cage in some books they are divided into three groups: the external, internal, and innermost group. But as some other books, they study them individually instead of classifying them into groups. But anyway, it's the same. We have external, intercostal, internal, intercostal, and innermost and subcostalis muscles. But before we go through that, we will study in the back the muscles of the back, that some muscles attached to the thoracic cage, like the levator costorum muscle, the serratus posterior superior, the serratus posterior superior, and the levator costorum muscle for the inspiration, and serratus posterior inferior is for expiration. These will be studied in the back, but today we are going to study the muscles between the ribs, the intercostals. Okay. Another point. Do you recall the accessory respiratory muscles we studied before in the head and neck? Yes, exactly. The scaleni, the scalene anterior, medius, and posterior, because they are attached to the ribs. So if the neck is fixed, they will act on the ribs, but due in exertion, in forced inspiration, deep inhalation. You know what I mean. After exercise, for example. Okay. Now, the external intercostal muscles, it's attached from between the ribs and from the rib above to the margin of the rib above to the rib below. The direction of fibers, like as if you're putting your hand in your pockets. So downwards and forwards. It's important to know the direction of the muscle. Downwards, then forwards. And it extends from the tubercle of the rib anteriorly to the costal cartilages. This means that it's deficient anteriorly above the costal cartilages till the sternum. You understand me now. So it's like a ribbon of muscle, but it's short of the intercostal space. So at the back, it's attached near the tubercle, near the vertebrae, and at the front, it does not reach the sternum. It reaches the costal cartilages. Instead, it's completed by a membrane called transparent membrane called the external intercostal membrane. They are 12 pairs, of course, and they are most active in inspiration. The internal intercostal muscle, direction is opposite, as if you're putting your hand in your back pocket. So downwards and backwards. Now, these are the internal intercostal muscles. Now, this is another ribbon of muscle that is short of the intercostal space, but instead it's attached anterior to the parasternum, to the sides of the sternum, and extends posteriorly to the angles of the ribs. So they are deficient posteriorly, and instead they are completed by a membrane, the internal intercostal membrane. So remember, the internal intercostal membrane, you can see it at the back. The external intercostal membrane, you can see it at the front. And if you can see muscle fibers through the internal intercostal membrane, these are the muscle fibers of the external intercostal. And if you can see muscle through the external intercostal membrane, these are the muscle fibers of the internal intercostal. Why am I telling you this? Because this is how they play you in the practical exams. For example, they bring you this this specimen and they put a flag on muscle fibers here, for example. So don't be tricked and answer internal intercostal. No, these are the external intercostals, but seen from the back. And the same story at the front. Muscle fibers visible through the external membrane, they belong to the internal intercostal muscle. The internal intercostal is most active during expiration. And the term most active means that they do work during inspiration, but fully functional with full power during expiration. This is what I mean. Okay, so this is the external and internal intercostal muscles. The innermost intercostal, same fibers, the same direction of fibers like the internal intercostal, so you cannot distinguish actually from inside, other than it's more prominent on the lateral side. They are more prominent on the lateral side of the thoracic cage, not the whole space like the internal and the external intercostal. And please keep in mind that the neurovascular plane, I mean the plane through which the vessels and nerves, the intercostal vessels and nerves pass through, is between the inner two muscles, means between the internal intercostal and innermost intercostal. I might make a mistake and say internal oblique like the abdominal muscles. Actually, the external, internal oblique, and transversus abdominis of the abdominal wall were continuation of these muscle sheets, but the ribs grew through the sheets. Okay, so they were one sheet, but the ribs grew through the sheets, so differentiated this into intercostal muscles, and the remainder downwards are the abdominal wall muscles. The subcostalis muscle, is present also prominent at the back, posterolateral, and it's unique that it's attached to the inner surfaces of ribs and passes one or two ribs to be inserted into the inner surface of the ribs below. See the subcostalis muscle. Don't confuse it with the direction of fibers is the same, but you will not be able to confuse it with other muscles because they pass ribs. Okay. The last muscle is the transversus thoracis muscle. It originates from the back of the sternum and costal cartilages of the lower ribs and extends 3 or 4 ribs high to the costal cartilages, so you can figure out its function. It brings down the ribs, and it's stated that its action is during forced expiration. Okay, but they are expiratory muscles, not for inspiration. Please recall that the internal thoracic vessels pass anterior to them, means superficial to these muscles. So these muscles are posterior or deep. I'm just giving you the terms that come in multiple choice questions. You will see the vessels pass in front of the transversus thoracis muscle. Okay, so now we know about the intercostal muscles and their actions. The barrel-shaped thoracic cage increases in size superior-inferior, transverse dimension, and anteroposterior dimension. Okay? Superior-inferior for the descent of the diaphragm. The diaphragm is attached like that to copulae and attached to the costal margin and back to the ribs, back to the vertebrae. When it contracts, it descends, so increasing the superior-inferior dimension, increasing the size, of course, of the thoracic cavity. What else? Anteroposterior, because of the it's a slight movement of the manubriosternal junction and the sternoxiphoid junction, because you studied before that. They are joints. They show minimal movements, yes, and because of the rotation of the upper ribs on their axis, the sternum is rather pulled anteriorly for a slight distance during expiration. This increases the size anteroposteriorly. And side to side increase in size, it's like the bucket handle theory. When the bucket handle is on the side of the bucket and you pull it up, the diameter increases. The distance between the peak of the handle and the center point increases as you pull it up. This is what happens to the ribs, especially the lower big ribs, the bucket handle theory, and this is responsible for the increase in size side to side. So now you understand how the the thoracic cage increases in size in all dimensions, actually: anteroposterior, supero-inferior, and side to side, with the bucket handle theory. For the blood supply of the intercostal spaces, we have a set of posterior intercostal arteries and anterior intercostal arteries of different sources, of course. For the posterior intercostal arteries, the first two spaces are taken up by the branch from the costocervical trunk. Now, do you recall the costocervical trunk? Yes, it's a branch of the subclavian. Which part? Second part of the subclavian, and it goes backwards at deep cervical, and then this sends an inferior branch that will supply the upper two spaces. Now the lower 9 spaces are taken up by the posterior intercostal arteries. See, from the aorta, from the descending thoracic aorta. These are the posterior intercostal arteries. See, they are beautifully dissected here, the posterior intercostal arteries. And since the descending thoracic aorta is shifted to the left of the vertebral column, so you expect that the right posterior intercostal is longer than the left. And trust me, this I got as a question in one of the exams, that the right posterior intercostals are, since they have to cross the midline and go to the other side, so they are longer than the left intercostals. What else? Like the typical spinal nerve, the intercostal artery on its way anteriorly, it anastomoses with the anterior intercostal at the lateral surface, and it gives a lateral cutaneous branch. Lateral cutaneous branch means that goes out and supplies the skin and fascia. Like the spinal nerve, the typical spinal nerves gives a lateral cutaneous branch and becomes the anterior cutaneous branch. But here it gives the lateral cutaneous branch since it's posterior. So please remember these points, important points about the posterior intercostals. They come out of the thoracic aorta, except for the upper 2 spaces from the costocervical trunk, and that they anastomose with the anterior and the lateral side of the chest of the thoracic cage, and the right ones are longer than the left ones. The anterior intercostal arteries are from the 2 sources, actually, but they are the same. The internal thoracic or internal mammary artery, this artery, internal thoracic, it comes from the subclavian artery, the first part of the subclavian artery, from the inferior surface of the subclavian artery. We studied this in details in the root of the neck. It descends back of the thoracic wall between the transversus thoracis and and the thoracic wall. The artery is lateral to the vein. Trust me, I got this as a question before. Yes, the artery is lateral to the vein. I don't know why the picture jumps in mind that the vein is lateral, since we are used to the fact that the veins are always superficial. No, the artery is lateral to the vein, and in each space it gives a couple of branches, one parallel to the inferior border of the rib above and one parallel to the upper border of the rib below, so double branches. And by the sixth space it divides into the musculophrenic and superior epigastric. The superior epigastric artery goes into the rectus sheath in the abdominal wall, while the musculophrenic continues to supply the lower spaces. Musculophrenic artery, it's a branch of the internal, terminal branch of the internal thoracic artery. Now you see these cutaneous branches. These are cutaneous branches from the vessels and nerves of the intercostals. These are cutaneous branches of an intercostal nerve, accompanied by anterior cutaneous branch from the internal thoracic artery. So what supplies the lateral zone till posterior is cutaneous branches from the posterior intercostals, and what supplies the anterior zone, anterolateral zone, cutaneous branches from the internal thoracic artery. It's very well obvious in this specimen. See the artery going down lateral to the vein, giving the double branches in each space. And remember, the internal thoracic by itself supplies the upper six spaces, and then the musculophrenic, which is the terminal branch, supplies the rest of the spaces. By the way, we always talk about 11 intercostals, and the 12th is the subcostal. You cannot say the 12 intercostal because there is no rib number 13. It's the subcostal nerve and vessels, the number 12. Okay, now another thing about the intercostals, that they continue in the abdominal wall to supply the abdominal wall muscles and skin and fascia together with the nerves. So we will be talking about them in the anterior abdominal wall. Remember this. Venous drainage. The internal thoracic vein, of course, begins as venae comitatis to the artery, and then unite into one vein. It's not here, of course, into one vein that is medial to the artery as they ascend, and drains the intercostal spaces the same way like the branches of the internal thoracic artery. And they have several valves, the veins, internal thoracic veins. The first posterior intercostal vein is called the highest intercostal. It drains into the ipsilateral brachiocephalic vein, while the second, third, and fourth spaces, are taken up by the superior intercostal vein on the right and on the left. The left has some important info in that it goes on the lateral surface of the arch of the aorta to the left side. It passes between the vagus, superficial to vagus, and deep to phrenic, and to empty in the left brachiocephalic vein. Again, the second, third, and fourth spaces on the left side are taken up by the superior intercostal. Don't confuse that with the highest intercostal. Superior intercostal, left superior intercostal, runs on the lateral surface of the left side of the aortic arch, superficial to vagus, deep to phrenic nerve, and empties into the left brachiocephalic vein, while the right superior intercostal also drains the second, third, and fourth spaces, but drains into the arch of azygos. This is the azygos vein. All this is the azygos vein. This is the azygos vein draining into the superior vena cava. See, this is the superior vena cava. It drains into the azygos vein. Now, for the rest of the intercostals, the posterior intercostals, on the right side, they drain directly into the azygos vein, as you can see here. See the vein draining into the intercostal vein draining into the azygos vein, see? And on the left side, it drains into, below it drains into the hemiazygos system, and above drains into the accessory hemiazygos, but eventually both azygos and hemiazygos and accessory hemiazygos drain into the azygos vein. Now, please recall that the posterior intercostal vein and the anterior intercostals are above the arteries. The vein, the artery, then the nerve. The lowest is the nerve. Okay? So this is regarding the venous drainage of the intercostal spaces. For the lymphatic drainage of the superficial regions of the thoracic wall into the axillary lymph nodes, we heard the axillary lymph nodes actually takes a vast area of the chest, including the breast, to parasternal lymph nodes along the course of the internal thoracic vessels, to diaphragmatic lymph nodes. They are present at the xiphoid, at the vertebral attachment, at the site where the phrenic pierces, and the intercostal nodes, some to the intercostal nodes of the back, to the heads and necks of ribs, especially, of course, along the posterior intercostal vessels. And eventually, all these drain into the thoracic duct, but the upper ones drain into an intermediary channel called the bronchomediastinal trunk, and then into the thoracic duct. Okay, of course, you know the thoracic duct exists only on the left side, but on the right side there is a small thoracic duct that is composed of three trunks, as we studied in the head and neck, but eventually opens into the junction of the internal jugular vein and the subclavian vein. Okay, about the innervation of the intercostals. The typical spinal nerve, this is a good question for essay, by the way. Write a short account on the typical spinal nerve. Of course, it arises from the intervertebral foramen and goes into the intercostal space below the vein and the artery. It's barely covered by the edge, lower edge of the rib they belong to, the intercostal groove. And they send a collateral branch that runs parallel to the rib below, so it's behaving like the artery. On the lateral side, it gives a lateral cutaneous branch to supply the skin and fascia at the lateral side, and continues to the front to become the anterior perforating branch. This is an anterior perforating branch of a spinal nerve. See this and this. Okay, what do they carry? They carry motor to the intercostal muscles, sensory to the skin and parietal pleura, and sympathetic for the vessels, of course. Now, remember that the sensory supply of the chest wall, of the upper chest wall, is taken up by the supraclavicular nerves as well. Remember the medial, intermediate, and lateral groups of the supraclavicular nerves, 2, 3, 4. And when we talked about the fourth, the lateral that encroaches on the shoulder deltoid muscle, skin over deltoid muscle, the medial and intermediate groups supply the upper chest wall. And also remember that T1 we mentioned in the neck, a part of the brachial plexus, is the same nerve that gives, is the same root that gives the T1 nerve for the first intercostal space. Okay. Also, there is a fact that the second, the T2 nerve, gives lateral branches, sometimes T2 and 3. And I dissected 2 and 3 before, giving lateral branches to the skin of the armpit, and the medial side of the arm. They are called intercostal brachial nerves. Intercostal brachial nerves. And also remember that the nerves, after they emerge from the intercostal spaces, actually down, they go to the abdominal wall to supply the muscles there. So we will talk a lot about the nerve supply of the muscles of the anterior abdominal wall coming from the lower 6 intercostal and subcostal nerve. Okay, so keep in mind these facts about the intercostal nerves. That it's a good topic for a short essay. Typical spinal nerve. You just say that emerges from the vertebral foramen, gives a lateral cutaneous branch, gives an anterior cutaneous branch, gives a collateral branch, and runs below the vein and the artery, and that they also supply the armpit skin and supply the skin and muscles of the anterior abdominal wall. Okay, now remember the nipple supplied by T4. This is an important information. Nipple is supplied by T4. Okay, last thing to say about the thoracic cage. There are different kinds of approaches, surgical approaches. One of them is median sternotomy, when if you're a surgeon and working on the superior mediastinum and root of neck, and you need exposure of the field, you can do a partial median sternotomy if you are working on the superior mediastinum. But if you are working in the thoracic cavity itself, on the heart, for example, or performing a pulmonectomy, you do a median sternotomy. You cut the whole thing from the suprasternal notch to the xiphoid process. There's another approach called the lateral thoracotomy incision. If you're working on the one side of the thorax, it extends from the anterior axillary line to the back of the scapula to expose the whole area, as if you're exposing the whole left lung, for example, if it was on the left side. Another procedure you will encounter, especially post-operative, which is the thoracostomy. Thoracostomy means ostomy means you make a hole, and you make a hole in the thoracic cage to insert a tube. This tube either to relieve a pneumothorax, for example, someone with flail chest like the one we talked about last time, and you want to get this air out, and you put the other end of the tube submerged in water. Or if you want to drain a hemothorax or pyothorax through this procedure, the thoracostomy tube insertion procedure. And when you are introducing the tube itself, when you are piercing the thoracic wall, remember to rub against the rib below. You go usually in the dependent areas, in the fourth or fifth intercostal space, in the mid-axillary line, or an area between the anterior and mid-axillary lines, and you pierce the thoracic cage, but remember to rub against the rib below. If you're going in the fourth space, for example, you rub against the upper margin of the fifth rib to avoid injuring the nerve, which is barely covered by the costal groove of the fourth rib. Okay, you got the idea? Okay, this is what we have to say about the thoracic cage, its muscles and blood and nerve supply. I hope you got the maximum benefit from this lecture, and thank you very much for watching.